Can you guys still see my screen?
Yes.
Okay, thank you. All right, welcome everyone. I'll give it just another minute here to let people join and then we will get started. All right, we'll go ahead and get started here. Welcome, everyone. Thank you for joining us for the third session of Indiana 211 University. As a reminder, we do record each session so that those who are unable to join us live can watch the sessions on their own time. Links to the recording of today's session, as well as the previous two that we did, can be found by visiting in211.org. After today's session, we would love to hear your feedback on our survey. You can access that survey by using the QR code on the screen or the link, which I will put in the chat here in a moment. And I do suggest opening that up at some point during the session so that you do not lose it before the session ends. See if I can get that posted. All right. And then as a reminder, if you plan to use today's session towards continuing education credits, then you do need to complete this survey and note that under the applicable questions so that we can keep a record of your attendance in case you ever need us to provide that record to you. All right, with September being Suicide Prevention Month, we do have a special guest with us today to present on this topic. Michelle Fox is the State Suicide Prevention Director with FSSA's Department of Mental Health and Addiction. Michelle serves as the State Suicide Prevention Director for the state of Indiana's Mental Health and Addiction, and is a licensed clinical social worker. Michelle is an experienced behavioral health services director and licensed clinical social work practitioner with an established history of working in the behavioral healthcare industry for 10 years, including suicide prevention programming, crisis response services, and community development. Michelle earned her Bachelor of Science in Psychology and Master of Social Work degree from Indiana University. She is a master trainer for the Question, Persuade, Refer instructor course, Adverse Childhood Experiences Indiana Coalition, Adult Mental Health First Aid, Applied Suicide Intervention Skills Training, and Psychological Autopsy Investigator for the American Association of Suicidology. Michelle is an advocate for supporting her home state with implementing trauma informed, community driven suicide prevention initiatives and promoting mental health well being. She has lived experience with suicide and mental health issues. Michelle enjoys backpacking, kayaking, running, time with nature, crocheting, and spending time with her loved ones. As Michelle is presenting today, if you have any questions, please feel free to put those in the Q&A section. I will monitor those and present them to Michelle to be answered throughout the presentation as timing allows. Otherwise, we will address all remaining questions at the end of the presentation as well. All right, we are very excited to have Michelle Fox here with us today. And without further ado, I will turn it over to Michelle.
Thank you, Sherry. We can go to the next slide. So our team, our strategic vision, mission, and values is to create an equitable and accessible suicide care continuum for all folks in Indiana. We're driven by lived experience, peer experience, being trauma informed, and leading from what the community wants. Some of our values include empathy, encouraging, listening, purpose, humility, unity, trust, vulnerability, persistence, and challenging power and privilege. And next slide. Our Indiana code actually requires the Division of Mental Health and Addiction to employ a suicide prevention coordinator and lead a statewide program for suicide prevention. So these are all of the components that we are required by the code to include. And when I talk about a comprehensive approach later, I will share with you a little bit more about each one of these that we include in our programming. And next slide. And so when we're talking about suicide prevention in the field of suicidology, we use some terms that you may not be familiar with. And so I wanted to take some time to kind of define these terms and what we mean when we are discussing these. So when we say suicidal ideation, that is self-reported thoughts of suicide that a person has or thoughts of engaging in suicide-related behavior. So that could include an attempt. When we talk about suicide intent, that is any potentially self-injurious behavior where it was not fatal and the person either changed their mind, were rescued, it did not lead to death. And then suicide means a death where there's evidence that self-injurious behavior occurred and they did intend to die. So a lot of times, and I'll talk a little bit about data in a couple of slides, a lot of times we know in the field of suicidology that suicide deaths are actually very underreported. And that is because coroners have a really difficult job. If they are not able to determine without a doubt that they had intention to die, then sometimes suicides do get ruled as accidental deaths, undetermined. And we also, September is Suicide Prevention Month, but it's also Prevention Month for substance use. And we know that there's a high correlation between suicides and overdoses. A lot of times overdoses don't get labeled as a suicide because it's really hard for coroners to determine that there was intention to cause the death. So we know that actually our data around suicide, it's a lot lower than what the actual numbers probably are. And then we like to also offer this other definition, which is suicide is an attempt to solve a problem of intense emotional pain with impaired problem-solving skills. So normally when I do this, I ask folks to unmute and tell me why they think that that definition might be more effective, which I know we have a lot of participants, so that's a rhetorical question for you to think about. Why might that definition be more effective? And when we talk about this, we talk about, an attempt to solve a problem. There's actually hope in that statement because folks are trying to find ways to cope with their pain. And we can help people develop other coping skills with that pain, along with the fact that this also kind of relieves some of the stigma and judgment around suicide because just as you would try to cope with any type of issue or problem in your life, it doesn't mean that there's a fault of this person. It means that they're trying to solve a problem. And then next slide, please. We also, in the field of suicidology, talk a lot about survivors. So if you were talking about, say, with cancer, somebody survived cancer, that means that they had cancer and they survived that. When we talk about survivors in this field, we're talking about the loved ones who lost someone to suicide. And we know that survivors experience a lot of intense guilt, pain, shame, anger, hopelessness, confusion, regret, self-blame. There's a lot of stigma and isolation, limited social support. Whenever I use this example, we talk about if you lost somebody to cancer, how many people are going to show up with the casserole dish at your house wanting to help you through it, talk to you, but how many people show up when there's a suicide? And it's not because folks don't want to provide that support. A lot of times there's so much stigma in and around suicide and the topic of suicide that people don't know how to talk about it. And so we know that that can lead to more isolation for survivors. And we also know through data that those who have lost someone to suicide are actually 4 times more likely themselves now to die by suicide because of that loss. So it's really important when you're building out your programming and outreach around suicide prevention that we think about survivors as well. And next slide, please. So some data, this is national data, and I always usually get questions, why is it from 2022? That's because in the field of suicide, our data is always 2 years behind when it gets officially released from the CDC. We can provide data in Indiana, but that isn't official data yet for 2023 because it still takes that amount of time for the federal government to put their stamp of approval on it. So in 2022, there were a little over 49,000 deaths by suicide in the US. 3.85 times more male deaths than female deaths. However, females attempt about 3 more times than males. When we talk about suicide death data, we always like to put it in the context of population data, because if I were to say, and this is me just making up numbers, but if I were to say there were 100 suicide deaths in Marion County last year, and a smaller county such as Cass County, if I were to say there were 12 suicide deaths in Cass County, folks would think, oh, well, that means that Marion County has more issues related around suicide, when actually the population is so much more dense in Marion County that when you put it per 100,000 individuals, you're able to compare them more side by side, if that makes sense. So in the US, we had 14.8 suicide deaths per 100,000. It was the 11th leading cause of death in 2022, which usually surprises folks. And folks usually, because of media and the way that we talk about suicide so less frequent than other issues, people would think that, oh, well, there's more homicide deaths, there's more gun violence on other people. But in fact, gun violence is mostly occurring on ourselves. So we have more suicide deaths via gun violence than homicides and other deaths. I think homicide in 2022 was actually the 16th leading cause of death in the US. And for youth in 2022, it was the 3rd leading cause of death in the US, which was surprising because normally it tends to be the 2nd leading cause of death for youth, but we did see that slight decrease in 2022. And if you want to think about this in terms of days, every day 136 people die by suicide, which equates to 1 death per every 10.6 minutes. And next slide. In Indiana in 2022, we had 1,152 confirmed suicide deaths. Our rate was 16.9 per 100,000 individuals died by suicide, which puts us 25th out of all states. Typically, that is true for Indiana. We tend to be between like that 22 to 27 spot. And we do tend to have a little bit higher rate of suicide death than the national average. And again, the highest method for suicide deaths was by firearms. In Indiana, 59% of all suicide deaths were by firearm. And next slide. This is the comprehensive approach to suicide prevention. So I like to give a zoomed out perspective and then zoom into our state's specific programming. So this is the national best practice recommendations for suicide prevention. This comes from the SPRC, which is the Suicide Prevention Resource Center. sprc.org if you're interested in learning more about each of these comprehensive approaches. So SPRC recommends that states take a comprehensive approach, which means that we focus on prevention, on intervention, on postvention, which means after suicide death, as well as the whole life continuum. Historically, especially in Indiana, suicide prevention has focused heavily on identification and assistance, increasing help seeking and how to get folks that are displaying warning signs, risk factors, do acknowledge having thoughts of suicide to professional support. But as you can see with this comprehensive approach, that is just a small component of effective suicide prevention. We also are building out, especially with the federal legislation to pass 988 in July of 2022. In Indiana, we're really building out our crisis care continuum, which does include suicide prevention. So responding to those at risk, having other supports like care linkages, effective care and treatment. We also are building out our postvention efforts. In Indiana, we are building what are called LOSS teams, which is an acronym for Local Outreach to Suicide Survivors. So that is a team that will provide immediate support to the loved ones after they have lost someone to suicide. We have 92 counties in Indiana, and I think currently, right now, we have 33 counties that are participating in that network. We also are building out our care linkages, effective care treatment, especially not only with 988, but also our CCBHC initiatives, and reducing access to lethal means. Again, we know that in Indiana, 59% of our suicide deaths last year did come from firearms. And so supporting effective, safe storage and secure storage and what that can look like. And then again, part of that comprehensive approach is building out these life skills, this resilience, and promoting connectedness. One of our highest risk factors for suicide is social isolation. And so we know effective connectiveness approaches are going to help prevent suicide. And next slide, please. Also, SPRC, in addition to their comprehensive approach for suicide prevention, has what they call the keys to success. So these are components of all of your prevention efforts that can help them be successful. So we know that centering lived experience at the core of everything is very crucial to having effective efforts. That is why our team, we believe in that and put that into our mission, vision, and values because we feel so strongly about it. The saying nothing for us without us. If we're going to build, for example, we have a whole youth suicide prevention federal grant initiative. And if we're going to build that, we must include the youth voice. And so what we did was we built a youth advisory board in partnership with the Indiana Department of Health. And so they actually advise us on everything that we're doing, as well as help us build those programs, and they also speak to legislators, leaders in the field, to make sure that what we're doing is the most effective for them. Building partnership and collaboration. Even though DMHA is by code tasked with building a statewide program for suicide prevention, we do not do this alone. We do it in partnership with our Department of Health, with our Department of Education, with our Department of Veterans Affairs, and all of our community programs. I was perusing the names of attendants right when we started, and I know several of you are involved in these initiatives as well. And then having safe and effective messaging and reporting, especially this being Suicide Prevention Month, it's really important that if we are building out awareness messaging, if we are communicating with the community after a suicide death, especially if a school experiences that, there are recommendations for how to do that safely so that we don't create, contagion, so more suicide deaths. And if anybody's interested in how to do that, Sam said the Substance Abuse and Mental Health Services Administration actually has a guide that's like 180 pages long around this, and I'd be happy to help anybody with that messaging. And then, of course, always culturally competent approaches and evidence-based prevention. Those have to be at the core of what we're doing. We have to think about serving a system for everyone, and using things that are evidence-based and promising practices. And next slide. In Indiana, this is some of our statewide infrastructure. So we have DMHA at the forefront, building, sustaining that infrastructure. We have an Indiana Suicide Prevention Network. If you are interested in joining, I can share that information with you. We do have a network of Indiana Suicide Prevention Coalitions as well. These are community grassroots-led coalitions that help to support the state plan and the infrastructure. We are very blessed in Indiana to have a nationally recognized chapter for American Foundation for Suicide Prevention. I think they've won awards nationally like the last 3 years. Do a lot of support around survivor peer-to-peer support as well, education and training, advocacy. And then, of course, our Department of Health. So we work hand in hand with our Department of Health. They actually house all of the data around suicide. They lead the NVDRS, which is the National Violent Death Reporting System. And they also lead social determinants of health efforts as well. And next slide. So these are some of our available programs. Typically, I have a whole 45-minute presentation on all of these. So I will just kind of touch on the ones that I think would be most interest to you all. And of course, if you are interested in any of these things or learning more, just please reach out to me and I'll connect with you or someone from our team. So we have prevention efforts. So early identification of folks. We know if we're able to get to them sooner, that's the better outcome. So things like QPR, which is question, persuade, refer, assist, which is applied suicide intervention skills training. These are trainings that anyone can take to be able to better recognize warning signs, risk factors for suicide, have a conversation with somebody that's experiencing thoughts of suicide, and how to get them to professional support. We actually do QPR instructor courses as well. So if you're interested in having an in-house QPR instructor to do those trainings with your staff, we can help support that. And we are building a network for assist trainers in Indiana as well, and providing workbooks for the people that will be training any crisis-related staff. So if you have crisis staff that you want trained in assist, you can reach out, and we try to make that more accessible to folks. So try to help with those costs. We also have Shield of Care, which is for juvenile justice staff when they have clients in their care, to be able to support them with thoughts of suicide, as well as NAMI, Ending the Silence. We do support that. That is a presentation for schools on common mental health issues, including suicide. And the great thing about that presentation that I like to share with folks is that they do include a peer, so a youth who presents, and we know that that peer-to-peer discussion is really effective. We also do skill building training, so trying to help support the clinicians and organizations that lead these efforts. So CAMS is an acronym for the Collaborative Assessment and Management of Suicidality. That is for any clinician in Indiana that would like to become certified in CAMS. I am an LCSW, and this is really the gold standard training for clinicians, that if you have a client with thoughts of suicide in your care, this helps you frame your sessions with them. And that is CEUs as well, which I know for us clinicians is really helpful. It's free. We also do the Zero Suicide Academy. So that is for organizations that are interested from the time that somebody would enter your system to the time that they leave your system, building out your suicide care continuum. And we have that available for free. All of these trainings, by the way, are for free. We have Safety A, which is another training for clinical staff for youth intervention in healthcare settings, as well as suicide bereavement training for clinicians if you have clients who are bereaved by suicide. That is not a specific intervention, but it's more an approach to how you support them. We have peer support programming available. We do support NAMI in the Lobby, which is a program in emergency settings, but we're also interested in building that out for organizations as well as Sources of Strength, which is for schools, building out their culture around mental health promotion throughout the whole school. And then Alternatives to Suicide. So this is a peer-to-peer support group. So the folks that lead these support groups are people that do identify with lived experience with suicide, and they are non-clinical. It is a peer-to-peer model that any organization can implement if you're interested in hosting those support groups. We also have loss support groups for folks bereaved by suicide. Again, the loss teams, which I mentioned earlier. And we do have our youth advisory board. So I know that was a really quick overview of all of that programming. But again, if you're interested, you are welcome to reach out to me and I can share more details with you. And next slide.
Real fast, Michelle, we do have someone in the Q&A section who said they are interested in learning more about the lost teams. Is there somewhere they can go to learn more about that, or should they reach out to you or someone else?
Yes, they can reach out to me, and I'll actually drop the link in the chat for them to learn more about lost teams. And actually, I will actually give you my colleagues' contact information. I think I can only, oh, okay, I can chat the panelists. So Caitlin Shore is our program manager for the Lost Team. So if you want to email her directly, and then I will also provide the link on the website for you to learn more about Lost Teams as well.
All right, thank you, Michelle.
Yes, good question. Also, I did just want to quickly share about our Black Suicide Prevention Task Force. So in Indiana, sorry, I'm trying to multitask. Here's the link for the last teams. So in Indiana, we back in, I believe it was 21, we had started to notice that deaths by suicide for Indiana Black males, including adults and Black male youth, their rates for suicide were increasing a lot more rapidly than other populations. And so we, in actually with the governor's equity team, we had decided to create this task force to help raise awareness, provide support, advocate for change, build collaboration, research and innovation around approaches for Black suicide prevention. We know that suicide prevention cannot be a one size fits all, and specific populations have specific needs. So if you're interested in being a part of this, I will share my other colleagues' contact information who is helping build this task force. I will say that it is in its infancy, and so there is definitely room for folks to get involved. We value your input, ideas. We do have subcommittees a part of this task force that are focused on specific things like faith, family engagement, data research. So if you're interested, please reach out. Charity Black is her name, and we would love to have you join our efforts. And then that is my portion. Next slide, if you want. That is my portion of the presentation. We did have another of my team members who was going to present on 988, but she is actually out sick today. So I am going to present on 988, but I do just want to give you all the caveat that this is not my program. And so if you do have specific questions, I will try to answer them to the best of my ability, but I do not want to give you any wrong information. So we do have an email address at the end of the slide deck that you will be able to submit questions directly to the folks who do manage our 988 program. So next slide. So our 988 Indiana vision and mission statement, the vision is to provide quick, competent, nation-leading crisis response for all Hoosiers. The mission is creating sustainable infrastructure to fully coordinate the crisis care continuum in Indiana, including for mental health, substance use, and suicidal crises. And next slide. So what is 988? 988 is more than just a suicide crisis line. 988 was actually born out of, if all of you remember, we had a 1-800 phone number. I think it was 1-800-273-TALK, which is what people used to be able to call if they were having some sort of suicide crisis. There were lots of folks for many years that were advocating for a better system, including infrastructure funding. And so what was born out of that in July of 2022, the federal government actually passed mandating legislation for all states to stand up crisis continuum services in their state. So 988 was born out of the call centers, and that is the first component of our crisis care continuum, but it is just the beginning. So 988 is a number that anyone can call to be connected with crisis support specialists for anybody experiencing suicide, mental health, or substance use crises, or any other kind of emotional distress. So it's expanded beyond, what the 1-800 number was. And next slide. And so we do have an introductory video to share about what is 988.
Michelle, could you hear that audio when it first started playing?
I did not hear it.
What is 988?
I can hear it now. It's quiet though.
Sorry,
When you share your screen, there should be a button that says share audio from a video as well. If that's not turned on, that's probably the reason.
All right, let me check on that real fast. Sorry, everyone. I'm going to stop sharing for just a moment and try that again.
It's someone who gets. What is 988?
I can hear that.
It's a way forward.
It's a free 24-hour suicide and crisis lifeline.
It's someone who gets you.
It's a listening ear.
It's whatever you need.
Even when you don't know what you need. If you are experiencing thoughts of suicide or a mental health or substance use crisis, call or text 988. Learn more at 988indiana.org. What is 988?
And next slide, thank you. So Indiana's plan, I started to kind of talk a little bit about this when I said that, 988 is really just, I'm sorry, the 988 call centers are really just the beginning. We are helping to build out the call center. So those are the folks, the crisis specialists who answer when you call 988. But we're also helping establish mobile crisis teams who are trained and skilled in responding to anyone experiencing mental health related distress. Those are composed of peers and behavioral health professionals who are skilled at providing that specialized crisis care to people on site in their community. And then again, beyond, the call centers and the mobile crisis teams, we are building a network of culturally competent support and life-saving follow-up care. And next slide. So beyond the call center, so someone to contact, someone to respond, the mobile crisis teams, we are also helping to build out short-term crisis stabilization centers. So these will be units that offer crisis support for folks who need a little bit more stabilization beyond speaking on the phone or getting that in-person support from a mobile crisis team, where they may need more time to stabilize at a brick and mortar type of building. So this is really, the federal legislation that passed in 2022 really helped us as a state to be able to advocate for a whole crisis care continuum. And this is something that we are committed to building for years to come. And really, this is only September 2024. So we're only 2 years beyond when the federal legislation passed for 988 and crisis support. So this is something that we will be building for years to come as a state. And next slide. And again, in Indiana, we're helping to build that infrastructure, connecting all of these pillars beyond the intervention. So the call center, the mobile crisis, the crisis stabilization units. We are building out our prevention efforts, which I talked a lot about during the suicide prevention portion, as well as postvention. So after a crisis has occurred, that follow up. In the suicide prevention field, we talk a lot about, if you are someone that speaks to someone that has thoughts of suicide, it doesn't end in that conversation. We know that follow up, that touch point beyond after the crisis episode helps build that connection for that person and integrating them back into their community and their supports, and it's a continuum. And next slide. And then we have another video about 988.
You've reached the 988 Suicide and Crisis Lifeline.
Para español, marque el número 2.
If you are a veteran or service member or are calling about one, press 1. To connect to support for LGBTQI+ youth and young adults, press 3.
So when someone dials 988, they can expect to have, a person, somebody who's real on that other end. They're going to hear that intro of, hello, 988 Lifeline, how may I help you? Or how may I support you? And by saying that, we're kind of building that connection of, hey, I'm just a person. I'm real. I'm not a robot. We're not some answering machine. It's not like all text or whatever. It is a person. When it comes to the definition of crisis, and everybody always tries to determine, oh, is this a crisis? Is it not a crisis? And our job isn't to determine that. Our job is to simply listen. Everybody can feel like they're in a crisis. Everybody can have their own symptoms or be experiencing whatever it is they need. And all they really need is somebody to listen. When I was younger in high school, even a little into college, I struggled a lot with my own mental health. I struggled with thoughts of self-harm, even acts of self-harm, thoughts of suicide. And oftentimes when I hear people tell me these, their own experiences, I can sit there and be like, wow, I thought the exact same way. And through that, you kind of build that connection of, we're both in this together.
So once a person requests an in-person visit through our mobile response, they can expect a 2-person team to come to their home, typically made up of a peer or a person with lived experience, and also what we would call a qualified behavioral health professional or a clinician. Once they're there, we would ask permission to come in and we would listen to what's going on, really just sit down and hear the person out, listen to what's causing them to feel in crisis, what is led up to that moment, and also times in their life when they've been resilient and have been able to solve that. We would do an assessment to see if that person needs further intervention, such as a hospital or a behavioral health professional that may be at a different level than we are. And we would partner with that person to really think about how do they want to come through this crisis? What are their goals? What do they want to work on? And how can we help them with resources? I think the benefit of having a peer or someone with lived experience is really that it brings empathy and understanding to the situation. They may not have gone through the exact crisis or the similar situation, but they know what it feels like to feel hopeless. They know what it feels like to be overwhelmed, and they know what it feels like to have hope and to move forward through crisis.
The Crisis Care Center, people can come into themselves, they can walk in, or they can be brought in by a mobile crisis team. In the Crisis Care Center, when they arrive, somebody will come greet them, and then a peer will sit with them and orient them to the program. They'll be able to get an assessment, and they'll meet with a nurse most likely and get a nursing assessment as well. The peer will help them with some safety and crisis planning to determine kind of what they need, and then we can get them connected to what they need. Crises can be all across the board. So it can be that somebody's just lost somebody recently and they're struggling to deal with that. It could be a significant mental illness that's creating issues for them at that time. It could be somebody's feeling suicidal or homicidal. Our peer support specialists are the ones who are introducing people to the Crisis Care Center. So they're letting them know that they have lived experience and that there is hope. They know that people are looking out and advocating for them to feel heard. So crises can really run the gamut. It's whatever is kind of exceeding somebody's capacity at the time for them to move forward and feel safe. Having a peer support, being able to say that, you know, I understand what you're going through in some ways. I'm not going through the same thing you are, and I never did, but I do understand what it's like walking in and asking for help and how scary that can be, but that it can be helpful, and treatment does work, and there is hope.
Thank you. So I really find that video to be very inspiring. And so in Indiana, we are very competitive. No, I'm just kidding. But we are, we are in the top 10 in the nation for our answer rate. And I know that our program leader, Kara Byro, is very proud of this fact because we worked really hard from the time that legislation was passed for 988 to have response center staff built up and trained to be able to answer the calls. And so here is a graph of the call volume from June of 2023 to July of 2024. And as you can see, the call volume doubled in, like a year, which is huge. And so we answer over, I know the next slide shows this, but it's over 90% of calls currently, which puts us in the top of the nation for answer rate. So we don't want any call to go unanswered. And the way that it works is when somebody calls 988, they will be routed to their nearest call center by their area code. And then if that call center doesn't pick up, it'll go to another call center and another call center in the state. And if for whatever reason we weren't able to answer, then it would be answered nationally. So the call will always be answered. What's next beyond the call centers is building out our interoperability with 911, with first responders. We want to have that collaboration. We want to have state infrastructure so that we can communicate with first responders and 988 and build that community engagement as well. And then next slide shows the number breakdown and the answer rate. So in July of 2022, the answer rate was 77%. July of 23 answer rate was 91%, and July this year was 92%. And I know ever since we have been able to answer within our own state, our answer rate has always stayed above that 90%, which is actually really great. And then the next slide is, awareness. So in Indiana, we do have our own 988 website now. It's 988indiana.org. So you can order promotional materials to help spread awareness in your community that are specific with the Indiana logo. And there are guides as well, digital guides on there to help you implement 988 in your organization. So you can call or text or scan the QR code. And if you would like to get some promotional materials, I haven't looked at the store in a while, so I can't remember if the stickers and magnets are available. I think if they're not, they will be as well. You also can always order as well from 988 federally. The SAMHSA storefront has more materials if you can't find what you need on our store. Or next slide, you can always email us at indianaIN988questions@fssa.in.gov. If there's things that you would like to see on the store, please let us know. If you do have more 988 specific questions, I do encourage you to submit them there because I am not the program lead for 988. And we'll get those answered for you. And oh, look at that. With that, we have 5 more minutes. I know Sherry's got a little bit more to share, but any questions, please feel free to raise your hand or unmute or type it in the chat. And thank you so much for your interest in suicide prevention and to help support this in Indiana.
Michelle, it does look like we have a question in the Q&A. Once a person goes to the stabilization clinic, will insurance be involved or is there a fee for service? Do you have an answer to that?
So I think that those things are still being built out. So I would submit that question. I know that with CCBHC, we are working with Medicaid to be able to support that. But again, I would submit that question to 988.
All right, thank you. And thank you so much for your wonderful presentation. We really appreciate it. If anyone has any last minute questions, go ahead and put those in the Q&A now. I will go ahead and let you know what our upcoming 211 University topics are. So on October 16th, we will have a speaker on domestic violence awareness. On November 13th, we will talk about veterans resources. And on December 18th, our topic will be adverse childhood experience and trauma-informed care. So be on the lookout for announcements about those sessions. And like I said, if there are any last minute questions, we can take those now. All right, so we do have a question about how does one get credit for the sessions. So Indiana 211 is an approved provider of continuing education credits. So as long as you attend and you'll want to use that survey link, which should be in the chat. And there is a question that asks if you intend to use this session towards those credits, and we will track your attendance in case you need proof of that record. But like I said, we are an approved provider, so you are able to log credits for these sessions. All right. Well, it looks like we do not have any more questions coming in. So thank you everyone for attending, and I hope you have a good rest of your day.